Lars, thank you very much for that introduction, and it really is a privilege to be here. Thank you for being here at 5 o'clock in the afternoon. I've had a remarkably privileged journey, privileged by the people I've had the opportunity to work with and to learn from. And in my current role as EVP of Health Affairs, risk is there every day, my understanding of it and how I respond to it, at an institutional level, at a personal level too. And this, I want to take us a little bit on some of the lessons that I've learned and some of the ways we are trying to approach it in a way that makes us safer, more reliable, more resilient in an era that is difficult. The reason that I've got understanding risk, it's really about getting to recognition and mitigation. We all know that there's risk, but getting to the heart of it, I think, is really important. If you can do that, then you're prepared in many ways. To embrace it is to really accept it, to understand that it's there. It does create uncertainty in all that we do, and I think no more so in cardiovascular care, whether it be surgery, cardiology, critical care, cardiac anesthesia. All of those disciplines are associated with that degree of uncertainty related to the risk. So I have some disclosures. They are, I won't be speaking much about any of these today. This tracking trajectory trigger tool that developed as a way in which to look at time series, high frequency physiologic data in a way to better understand the direction of a patient's course in response to management. MyHeartPass is an app that we've developed to look at how we can improve the resuscitation of children with heart disease. AtriumDB is a web-based platform, is an architecture that was developed to assist kids to use high-frequency physiologic data in terms of capturing it, storing it, compressing, and using it for modeling. And the last one there, Risky Business Events, started in 2006 when I had the opportunity to work with 3 other colleagues from Great Ormond Street in developing a series of conferences around risk management in healthcare. And the underlying tenet was that we can learn from other industries. On the right-hand side there are numerous, your left-hand side, are just highlights of many speakers, themes that we've addressed at these conferences over the years. And the website, riskybusiness.events, is open source, accessible, and some really great stories of success, stories of disaster and recovery that I think are inspirational in many ways. And what I've learned from that is we're not alone, that we face opportunities and we face challenges, but there are equally opportunities that we can create to overcome those. And each industry, high-risk industry that is presented at these conferences have all demonstrated that ability. We are unique in healthcare. We can't be lumped in one bucket, and we are complex, so one size does not fit all. Our systems differ. Perhaps they shouldn't, but they do. And one of the things that successful high-risk industries do is that they harden their systems. It doesn't mean they become fixed and inflexible. It means that they harden the way in which they approach risk and decision-making, and they harness data, and they use both of those to enable people. And I think that's the key message. The other is that high reliability works. So high reliability, I will come to in just a second, but we've needed to really apply it across Boston Children's because despite COVID, despite all we've been through in the last 3 years, there's been this relentless forward progress that is frankly exhausting and is difficult for our staff across the enterprise. First of all, we have our additional clinics that we are, and building that we opened, the Hale building in June of 22. We have additional buildings for ambulatory services, surgery, our Waltham satellite, and then complete renewal of our existing buildings. And that's a sort of a 10-year plan, and we're well underway with that. But some of that got on hold with COVID, but that's all moving forward to eventually we have 500 beds as our capacity. In the meantime, we've also taken on a collaboration with Tufts Medicine, Tufts University Medical School Department of Pediatrics, and we now are responsible with them for Tufts Medicine Pediatrics. Franciscan Children's Hospital, we have a strategic plan, an education plan that's about to launch. All of those are going along at the same time as we've had to try and manage through, as all of us have, the COVID, behavioral health, capacity, occupancy concerns, staffing levels, and so forth. And on top of all that, we're going to Epic. We've been a Cerner shop since 2005, and now we're an island in the sea of Epic. And so we are now becoming Epic, and that's happening next year. So we're adding that to the mix. And it creates its problems if you want to be highly reliable. In particular, how do you thread that needle so that everybody's preoccupied with failure, that we are paying attention to detail and not simplifying, that we're deferring to expertise, that we're sensitive to all the operations that need to take place, and that we enable resilience and therefore recovery when events occur. They're the fundamental 5 tenets of a highly reliable organization, and we're trying to make sure that we are part of that. We have finished our 2-3 years ago, just before COVID, our version 1 training. We're now about to launch version 2, and SickKids has also undergone a broad system-wide high reliability training. But I would say that the healthcare is not a reliable system, and we've proven that in the last 3 years. Just look at the impact of COVID-19 and our response. Look what has happened with our workforce, availability, experience, the costs. Look at the impact on all of the bottom lines for almost all systems across the United States. The surges we've had to manage from a pediatric perspective at the end of last year with viral illness, behavioral health, all creating capacity and occupancy concerns. We have not scaled. We have not been able to translate between systems across this country. We've had ambiguous regulations. And on top of all that, there's been this, at least in pediatrics, a drive towards how do we optimize resource utilization, and can we do that through regionalization? And that's a big issue right now for pediatrics. I can't speak to adult systems. But if you look at currently where pediatric critical care centers are across the United States, and that top right-hand graphic or cartoon there, those dots represent either a dedicated pediatric cardiac ICU or a joint medical pediatric ICU. This was published in 2020, and it was data from the United States in 2018 from Robin Horvath and her team out at LA Children's. When this paper was first reviewed, a number of us asked if we could overlay population densities on this to see exactly where things fit. So I think it's very interesting that you can see the density of populations around the centers in the Northeast and the central part of the United States. On the West Coast, despite the population, I think you probably have already centralized or regionalized a lot of the care. I think the care that's provided up here in Portland is really important given the population, given the distance that people need to travel. And it's easy for us to say to regionalize and transfer patients. It's extraordinarily hard on patients and families. And I don't think that's actually necessarily the right thing to do for them at all. There's a big concentration out on that East Coast, isn't there, in the not so much on the West Coast. And the flyover central USA, yes, certainly there are some population differences, but we have work to do to make sure that we have got equitable service across all of our areas in pediatric cardiology and critical care. So when COVID came along, I'm sure this was an expression that all of you used, flying the plane as we built it. It was a metaphor that was used almost on a daily basis. And we had our emergency management team activated, our HICS team activated for over 300 days for that first wave of COVID. They produced a tremendous after-action report from which we learned a great deal. And then 12 months later, when we had our major staffing issues, the problems with ongoing with behavioral health, a new surge in COVID, and other issues, we had to reactivate our emergency management team, also for an extended period of time. And we had a playbook that we could use, so we could fly the plane that we built. But I don't think we flew it as very well because we didn't have navigation. And that navigation was in the form of data that we could actually use. And it's not epidemiologic data. It's not data about, well, this is what happened. We look at it downstream, and then we make some conclusion, say, well, if only you had done that, this would not have happened. That doesn't help us. We wanted something that was real time, and I know that this is work that was also done at OHSU around what was happening with the trajectory of viral illness in the Northeast that was going to impact our occupancy capacity, what was the impact of behavioral health and so forth. So that strategy was very important for us, and I think we have actually learned a great deal from those first after-action reports, and I now believe we can fly our plane with much better navigation. It's taken a fair bit of convincing, and by that navigation I mean using real-time data, having dedicated teams in an aligned intelligence platform that is giving me as a decision maker real-time information. It's also giving everybody else real-time data as to what is going on and what the trajectory is. It made a big difference to us in terms of how we could plan forward. Because we really have to stop going around in circles. I don't know whether you feel that, but I felt that both at Sick Kids, I felt it at Boston Children's, where our current status tended to be one we detect and then we respond and then we drift. The number of times I hear of repeat events is it's unacceptable and it's unnecessary. And what we really need to get to is this predictive, preventable state where we harness our system, harness our data and harden our systems. And this is the approach that we are taking now, is to say, okay, we have a macro system, and that's our major problem in Boston Children's, is to define what that is. But understand the macro system, how people are working within it, the impact that system has on the workforce and the teams and how they can deliver the care that they wish to deliver and we need them to deliver. And what are the tools and technology they need to be successful. So our approach is on all challenges is this sort of lens. Now we have an outside consulting firm every year that comes in and gives us an estimation of our risk. Honestly, I don't find it very helpful. It just doesn't usually give us new information and doesn't tell you where to necessarily put your resources or where your biggest risk is coming from. And there are big problems. Should we standardize or should we accept variability? And how do we align people? How do we capture the work that is done by people, technology, data? We have over 300 programs. We have multiple other service lines. And the only time we really find out that there's a problem with a program is when an event occurs. We should be ahead of that, but we're not. That takes us shifting from this reactive to predictive mode. We generate reports all the time. We have our benchmarks. We submit to registries all the time, as you do as well. Does it help us? I'm not sure. I won't dwell on that, but I think it's not necessarily that real-time assessment that we need to estimate the risk and respond appropriately. I do think we need a category of engineering that appreciates risk, and it is an engineering exercise. I think observers make a difference. If you look at Formula One and NASCAR, they have observers of not only the technology and what's going on with the car, but where that car is at any time, particularly NASCAR, in NASCAR races, where that car is at any particular time in relationship to cars around them. And that's an observer who is actually conveying that information to the driver, real time. We don't do that. And we need to make sure that we bring in content and business expertise. My problem with this type of risk assessment is that the people who don't necessarily have our content know our business well enough to be telling us where the problems are. We have to be able to do that internally. So this is the way we structure ourselves at Boston Children's. We have a board of trustees and a president, CEO. Look how siloed we are. Research, which is massive. We have all these departments and foundations where clinical work is provided. Underneath that is the trust, which raises nearly $200 million a year to support these work. On the horizontal side there, we have Office of General Counsel, Finance, Human Resources, Patient Care Operations, Facilities. They have their own structures within, and then I came into this role as EVP of Health Affairs. And underneath that is basically our relationship with the medical school. I'm the chief physician in the hospital. I'm their advocate, our advocate, sit on the executive committees and so forth, with lots of other groups underneath that, but really responsible for the quality of care that we deliver. But you can see already that that type of structure leads to discord. It also leads to failures in communication and people unable to swap between lanes. And even though we try hard for that to not occur, inevitably there is circumstances where that does occur. So we're trying to make sure that we actually underlay all of that structure with some really important tiger teams: EDI, risk management, process improvement, our immersive design system, which is what we've rebranded, our simulation, which is really systems engineering, how we educate and communicate and transfer information, and then our application of information technology. So every time we've got an initiative or we have sets of problems to do, rather than trying to solve it within one of our siloed areas and bring other people across, we have teams that will actually go across the system. And that is working very well most of the time. We have to watch very closely to make sure that people don't get stuck in their silos, but that we have the right people allowing us to manage and understand that risk at all times. So let's go to the Hale building. I mentioned how this is sort of Boston Children's as a global view. The Hale building we opened in June of 22. Great new cardiovascular, well, 6 floors of cardiovascular, and then NICU, some OR, some general surgery. It's an amazing acute tower, state-of-the-art. From the heart center side, we have 5 floors with 48 ICU beds, 48 acute care beds, which is our cardiology ward, 5 ORs, 5 cath labs, a hybrid, all sorts of space for clinics, imaging, and so forth. This building was designed in 2015, but no expense was spared, and the technology is remarkable. Completely new automated technology in lab medicine, pharmacy, and sterile processing. Just, it's really quite amazing to see it all. To see it is one thing, to make sure it works is another. And we put in new monitoring systems across our critical care areas and ORs as well. The size of the building is such that it was double the footprint from what we had previously. It is very difficult for support services to get to us from other buildings, believe it or not. There are no MD offices other than some service or call offices, which has meant that the physicians and decision makers are remote, and it is made it difficult to communicate and have that effective collection of people, the curbsiding and things like that. To go off the floor to do other tests and procedures is a real undertaking. So and a few other things like we had to build in redundancies because this building is now duplicating resources in another building. The communication lines of sight, all of them are challenging. Now, you would have thought that we should have known all that. And in fact, we prepared immensely. We knew the size of the building, we knew what it would take, so we simulated continuously about distance and safety nets. Our design engineering team, Immersive Design, worked tirelessly to make sure that we were doing the right simulations. Everybody embraced newness. We employed, at the time that there was the Great Resignation, we were able to employ an additional 800 staff to open this building. And we had a scorecard that we tracked very closely to make sure that we could avoid harm. We transferred patients in 2 stages without incident or delay. That worked like clockwork. But I can tell you 6 months later, and even though we had a phased intent on phased expansion, within 6 months, the challenges of that building started to become very apparent to our teams. It's a wonderful space for families, it really is. And there was no harm that we could see or that we could measure to patients. But there was a rapid increase in volume. Instead of phasing in over a period of, it was planned to be 6 months to get to 48 beds, within 2 weeks we got there. It's just, and that was because we got a surge of newborns with heart disease, and it was incredible stress. And that tension has persisted on the staff. It's been relentless. They are tired. Add to that the fact that we've got an inexperienced staff now with turnovers. You've experienced exactly the same. It's placed incredible tension on more experienced staff to be doing the education, to making sure that the way in which we worked in the past can continue. Communication and connections have been disrupted. And there is, I'm going to use the word moral distress, but I think, and fatigue, but there's also concerns over psychological safety. The technology has needed a lot of adjustment. It's great. It's nice to be automated, to send a specimen from the bedside down into the lab and not have a person touch it. Doesn't always work. So we've had all of those tensions to put into the mix here, and it's been tough. I know I'm sounding negative. I don't wish to. It's a fabulous building. I attend there, finished week of service not so long ago. But the impact of opening this building on top of all the other things that we're doing has been huge. And one of our problems was that, how do we define our system? And if we've defined it more as a compliance system, so that what's the unit change in volume per unit change in pressure? It's like a lung, so that we will, as the capacity, as the pressures change around capacity and access and flow, and how do we increase that ability to meet that demand? We just keep trying to expand, and you try and ask more of staff, create more spaces. So we were, and I probably still are, a very compliant system. What we need to be, I think, is a very elastic system. We need to be the inverse. We need to be more like a ventricle. What's the unit change in pressure per unit change in volume? We need to learn how to contract and relax. We need how to manage downstream loads, afterload. And we need to be able to know how to come together. Just like myocytes pull on each other, we need to know how to do that. So I'm trying to shift the way we think about our system as being compliant to that as being elastic. Not like the lung, more like the myocardium. And that we map and measure this with complexity and the various moving pieces, that we have focused initiatives, appreciate that nothing's sequential, or not always sequential, and that there is risk inherent within. And a very important part about that system is understanding the psychological safety that people feel, so that they can not only speak up, which is clearly very important, but create that learning system where there's purpose and value. And it's not about people adapting or even transforming. It's about creating that learning system that enables the networks, the connections, and the execution that's necessary. That's this type of system that we need to be able to generate. Because if we don't, then our teams are going to fail. This is Mark Durand. He's got a video on the Risky Business website, that some of those 2 or 3 videos, and they're terrific. And he talks about teams as a unit, that we treat them as a unit of analysis, like they're an individual component, and not that they're comprised of people with distinct strengths and skills, personalities and culture. And he would say that if you can get by without a team, then do so. But obviously we can't. I observe your teams today, Lars, during rounds, and they're like the teams we have in Boston. They're changing continually. People are coming in and out every time. It's a very dynamic experience. And we have different generations within the same team with different expectations around the tools they use and the information they expect to be transferred and how it's transferred. All of these factors that I've mentioned here can lead to problems for the team. Deviation from what's expected. How do we navigate the system can be very hard. So if we don't have the system right into which our teams need to work, then they will fail. And I think one of the problems we had in Boston is that when we shifted into this new, spanking new hospital, is we took the old system with us into a new environment, and we didn't rethink that system well enough. And that was a mistake, because then we had our teams working the same way in a new environment, and we set them up for stress and tension. That's on me. That's a mistake, and we won't make that again. But it's been extremely hard for people. They have risen to the occasion. It's unbelievable how resilient we are. It's remarkable. Rising to the demands, to the needs of patients all the time. That's just unquestionable. It's not sustainable. Within pediatric critical care, we have tried to wrap around a system for patient care. We know on admission their diagnosis, make some risk adjustments based on that diagnosis and their management, and we have an understanding of what the discharge should be. We wrap that around with an environment, our teams, our workflow, and various aspects of guidelines, early warning systems, quality metrics, and we wrap that around a patient and we think, okay, we're on the right journey. And then we tend to do this. These are decision nodes. We bounce around in our decisions all the time. I often hear that that's what you like, or X likes, or Y likes, and it's not really what I like, it's what's best for the patient. And it's the decision-making and the nodes and the variability is that of practice variability. And I have colleagues who would say to me, absolutely, it's because you're thinking about things in a different way, or you're not thinking about it correctly, and we should just have consistent practices all the time. I think that's wrong. We're working in a intensive care unit where there is biologic variability. And this biologic variability means that decisions have to change. But they can't change in a haphazard way. There needs to be some understanding as to why the change is occurring, and that needs to be expressed and captured. We don't do that latter part very well. But we deal with patients who have biologic variability and they need individualized and precise care. And the monitoring devices that we use are going to give us that information. How much data do we generate? Well, at Boston Children's for the last 10 years, we've got just on 13.5 million hours of data from 150,000 patients, or 560,000 patient days, which we are accessing and using to try and model and understand trajectories. My lab that continues at Boston, at SickKids, lawsonlabs.ca, we've been capturing high-frequency waveform data since April 2016. And on this lower right-hand corner, that graphic there, We're now just on 5 trillion data points in that period of time. Every waveform from every device captured and stored. And to be able to manage that, we had to build an architecture that enabled us to not only capture it and solve the bottlenecks in the data which occur, but also then to store it in a way that is efficient and highly compressible, but then rapidly decompress it so we can get to the data and use it for any modeling. And the idea is to be able to take this modeling and use it real time at the bedside. We've got some work to do on this. It's not easy, and there's no system out there that allows you to do it. But there's no point capturing the data and saying, I've got it, thanks very much. You've got to be able to have an architecture that allows you to use it and model it in a way that makes sense, and that's what we're trying to create here. This T3 tool, Tracking Trajectory Trigger tool, I was a co-developer on, and the aim of that was to really represent data in a different way so that we could, at the bedside in the ICU, zoom in, zoom out, look at trends, look at that trajectory, that it had a usability that allowed us to look how signals actually interact, and then measure new signals by calculations like coronary perfusion, calculated every 5 seconds and displayed. So you can actually see the trends of these various aspects of the monitoring that we're doing. So it's not designed to tell you what to do. It's a different tool that allows you to aggregate information and look at it over time. And then it's a hosting platform for modeling, and this is one model that we developed called Inadequate Oxygen Delivery. It's a Bayesian model, straight out of Guyton, for all the factors that contribute to oxygen delivery. This is a Bayesian model that's calculated every 5 seconds by the data feeding into it from the bedside and displayed on the T3 platform. It's an estimation, it's a probability, and it's another difference in the way in which we practice, because we tend to be binary. We like to be right. We like to be sure. And to be able to then factor in, well, this is the probability of this situation into your decision making is different again. There are other ways in which to look at the data. Here is one example of hemodynamic signals associated with new brain injury after congenital heart surgery. This is 77 patients at Sick Kids data captured in our lab. 77 patients, 60 had the arterial switch procedure, and 17 patients underwent single ventricle reconstruction. They all get a brain MRI pre-op and then 9 days post-op. And you can see new post-op injury on the transposition group was 32%, and on the single ventricle group was 41%. Now, these are not devastating injuries, but they're new findings on MRI that indicate that there's been some change to perfusion in the brain or some embolic event potentially that's resulted in that. So if these post-operative changes is occurring in the ICU, what's contributing to them? How can we be ahead of it and prevent it? And so Jessica Nickel, who was a senior fellow in the ICU at Sick Kids, looked at this patient population to see what we could determine. And if you look at this set of graphs here, you really can't determine anything. You look at blood pressure, you look at pulse pressure, or pulse rate, SpO2, a lot of red and a lot of blue. You can't really draw anything out of that, and it's not as if one signal it's in of itself is responsible for the new injury that you see. But when you start to do first principle component analysis and apply some mathematics to this, you can start to see on this that there's actually new injury that's related to a lower oxygen saturation, a higher blood pressure, and a faster heart rate. You can start to see the components that add to risk here. Now, the next step from this type of information is to be able to display it real time, and we're working in a way in which that can be displayed, but also you've got to test for it now. What are the if that is the set of parameters that result in injury based on MRI findings, what are the interventions that we need to put in place, and then to measure that? We can do that very well because we're collecting the data. We don't have to do a randomized controlled trial. We continue to use and collect huge amounts of data, but we need to capture decisions and treatment with that data. So we need to understand, finally, how we work within our systems. And human and systems engineering is very important. And when I was at SickKids, I was really fortunate to work with Patricia Trowbridge and Sonia Pinkney from the University of Toronto. And we ran a number of studies trying to understand this within our ICU at SickKids. And I think it's probably just a couple of illustrative points. The first is to try and implement any change wherever you are. You have to understand how people are thinking where the change is going to be implemented. So that's our macro cognition. So we first looked at this trying to install new technology into the ICU at SickKids. And we looked at physicians, and we compared them to pediatric nurses and to respiratory therapists. This is the ICU physician data. For ICU physicians to adopt and accept a new innovation or device within the unit, that first of all, the central process we used for using it was what's the problem we're trying to solve, and then does it make sense? And if it didn't make sense to us, to physicians, they weren't going to use it. In other words, if it wasn't explainable, if it wasn't believable, it's not going to be actionable. We have to move from that. Our black box gets in the way. But that was, without knowing that, I don't think we would have been able to overcome a lot of the implementation barriers that we've seen. Sense making is very important for physicians. For the nursing staff, they actually had a different set of macro-cognitive processes, and it was primarily around managing complexity. If we implemented something that just made it more complex for them at the bedside, it created more uncertainty and risk and affected time management, they weren't going to use it. So making sure that how you change fits with the way people are thinking. It's very hard to change people in the way they think, but we can change the tools we implement to enhance the way they think. We just first have to understand it. The second is, how do you make sense under conditions of uncertainty? And the signal detection is, I'm sure you're all aware, there's two components. There's the perception of the signal, so how to discriminate the noise. And certainly tools like T3 that I talked about could boost the signal, but it can also add more noise. The other is the decisions that we make, and that is really at the comprehension, the action thresholds we have for responding to what we see evolving. And that usually comes down to pattern recognition. We don't do that effectively, all of us. We do it in different ways. And I think there is a real role for the modeling platforms to really help us see those patterns that are emerging, and therefore the risk for an event within. And we do it differently whether we're experts or non-experts. So the non-expert, less likely to recognize the cues, more likely to be sequential in the analysis, and less flexible in changing the plan. Whereas the experts, differentiated because they have specialized knowledge, they have experience, understand cues, recognize patterns more likely, and they have an active process to change original thinking with new information. So they're looking at data to try and disprove what they're thinking. That's a really important assessment of benefit versus risk. And we've studied that with this application I talked about, My Heart Pass. Azia Asadi completed her PhD recently at University of Toronto, looking at experts and non-experts and how tools can help us level that playing field, and how they can be used to really help us recognize the cues, understand the patterns. Finally, we looked at our time motion studies in the ICU. How do we work as a team? We started off with 65 hours of observation, 57 rounds, nearly 800 patients. And the first thing we came up with was clear was that our process of rounding was all task orientated. It was what to do and how. It was documentation, list and plans. It was observed that we had an entourage-like effect. There was people all moving together, centered around 2 or 3 key people, that there were a lot of distractions and interruptions, that we had put in bound time constraints. I've got to get to clinic, got to get to the OR, got to meet this person. And that workflow and bed mitigation were other constraints. And there's a lot of repetition and a lot of work to try and close loops that we didn't always succeed in. This was the observation from people who don't work with us. They were quite amazed that we actually got anything effective done. But it was clear that we were very task-orientated, which is not what we should be. It's really important that we are that component, but it's not, to me, the principal component as to how we should work. It's understanding why we're doing the job, why we're making the decisions, and what we're tracking as the key indicators of the decisions that we're making. We then applied a systems framework to understand how we can look at latent safety events. So system-based events that can occur at any time, they affect our performance and our outcomes. And these latent safety events are commonly determined after an event. So they're reactive, there's recall bias, and they're difficult to categorize. So we decided we would do it through a human factors lens with observations. And so this was another 188 hours of observations over 4 months at all categories of people working in the unit. And we did a thematic analysis looking at these 5 components to the SEEPS framework. And we put together this, as a result of this, and I'll show you some data on this in just a second, how a framework that allowed us to perhaps assess how we are behaving in circumstances of uncertainty. And there are really basically 4 components. There's this one here, which is really standard work. No uncertainty, you don't need to adapt or change your behavior. It's how you, in intensive care unit, it's how you're going to place a central venous line, how you're going to access those lines. And it's just standard work. There's this group, rigidity, where you never want to be, where there's lots of uncertainty, but we're not shifting at all. We're not appreciating it. And that's really where high reliability training comes in and understanding the risk for harm. This is an important quadrant to be in, where we can respond and recover appropriately. And that's the sort of the resilience. So there's a lot of uncertainty, but we're adapting and changing behavior accordingly. Now, to understand how to train and gain experience in these areas, it's important. So checklists, CPGs, simulation, they can help with standardized work in this bottom left hand. Up the top there, a checklist will never work. You need to have trained, you need to have had what we call immersive simulation, but you also need to have data and intelligence and model. That's really important. And then finally is this particular one where there is a lot of variability, but there doesn't need to be. People are doing things that you don't expect or are unnecessary because the uncertainty is not there. It's also called normalized deviance. It's also caused unnecessary adaptation. At sick kids, 25% of the time we are in this zone in our ICU. Only 25%. Less than 5% in the rigidity. Less than 15% in the resilient responding. Nearly 50% of the time we were doing workarounds. And we didn't know it until we started to really evaluate it. And so for me, the definition of a system that was working well is that we're capturing the workarounds and understanding it, because workarounds are not wrong. Workarounds are people adapting to situations, and they may be adapting because the system sucks, or because there is a problem with the way in which, the environment in which they're working, or, and very importantly, they've found a better way to do it. So we have to capture all of those. This is the human factors analysis and latent safety threats. Turns out, without going, just for the sake of time, that the greatest risk for latent safety threats is in that zone of variability that I showed you. And for that reason, I think it's the learning system. That's, to me, where we learn, and we have to capture. And that's, I think, important across not only a unit effect like the ICU, but it can be applied more across an institution as well. We need data to do it. This is our aligned intelligence at the bedside platform that we've been running now for over 12 months at Boston Children's, and it's called alignment because it's not so matter, it's aligning sources of data, but in particular people with that data. And we're using that to model both operational and clinical functions. Meeting challenges, building opportunities. Address the system, understand the system, enable the workforce and the teams within that system, provide them with the tools and technology to be successful. That, to me, is what we need to do in any organization, but particularly across healthcare right now. Thank you. I'm happy to take any questions. Thank you very much.
Thank you very much, Peter.
Yes, sir.
You know, it's extremely interesting. And you know, when I sit here and think about it, we're doing these things when we're working in an intensive care unit. We're also doing it when we work in a research lab. We're tracking something and trying to see where it goes. And we also do it in clinic, but also in a slower way. And one of the challenges that I've had, both in research and in clinical medicine, when one's tracking someone, or something, and seeing where it's going, where you set the threshold for change, and then once you've changed what you set as your next threshold to where you're going. You understand?
Oh, yeah, I get it.
So what's your wisdom? What's your insight there?
Well, I wish I had the wisdom to give you the right answer for that.
I'll take insight.
So, first thing we need to do as a profession is capture the decisions we make so that we can see the impact of the treatment we made based on that decision. And we can infer it from the EMR. We can, blood pressure fell, we went up on epinephrine. Okay, so we decided we'd make the heart work harder, and that was enough to correct the blood pressure. But it doesn't tell us what we did, it doesn't really tell us why we did it. Myocardial function may have been fine, we just wanted to push it harder. Until we can start to do that, I think it's going to be really hard to develop thresholds to start with. And that's going to be a lot based on downstream results, and then, and I hate to use this word, but on consensus, on what we as clinicians at the bedside believe is the right target range. We've seen that with blood pressure. We have kids come back from the operating room. We have 10 cardiac surgeons, and they'll vary in their target ranges for blood pressure. And quite frankly, some of the target ranges are going to induce hyperperfusion of the brain, but I can monitor cerebral perfusion pressure on T3, and I can say, no, we're not going to do that, but we'll take this target. So I'm not giving you a clear answer, but our approach has been one of following the data and that trajectory and with the outcomes, and then going back, circling back all the time. We circle back enough, we capture our decisions, we're going to get a lot easier. Of course, easier said than done to do that.
Thank you.
Thank you. Yes, sir.
Thank you so much for a wonderful and really provocative approach
Thank
to
you.
how we organize our daily lives in an effort to improve reliability and safety. What are your thoughts relative to how our workforce competency has evolved, or more importantly, not evolved in terms of bringing in the competency and expertise to do this type of work, to change the way we care for patients by improving decision making? Large data, machine learning, artificial intelligence, data engineering, are all things that are not taught in medical school, and certainly are not areas where we make large investments in the personnel as team members.
So, very important question, and it really reflects the way we have to remodel our delivery of care and the way in which we're taught. At Sick Kids, and now in Boston, we built an engineering team that were embedded with the clinical team in the ICU. I didn't show them on the screen, but one's a physicist who's an expert on earthquakes and seismology. His ability to understand signals is better than anybody I know. Another is a computer scientist who developed our data architecture. We have people who are outside of healthcare, but are bringing and translating their skills in engineering, whatever it be. They have to be embedded within our units. They join us on rounds. They understand the problems, and that's the first. The second, I think every intensive care unit or system in a hospital should have a human factors engineering section employed within. And their job is to follow us and to watch how we're working and understand what are the barriers for us to do normal work, capture those workarounds. And I get the pushback I get, of course, from my CFO, and Doug and I work very closely together. We have adjacent offices, is we can't afford to do that. My approach is we can't afford not to. You know, if we're going to bring because we can't, our workforce is itinerant. People are coming in and out. They have skill sets. They have competency. Our mistake would be to say they have no value. We have to get just-in-time learning at the bedside. We should have virtual reality learning at every patient so that when a patient's about to be admitted, and this is done in EDs in numerous places, it might be done here, I don't know, where you're about to accept a patient, you put your VR goggles on, and it shows you exactly what the circumstances are. Post-arterial switch procedure can take you on a tour through the heart. These are the risks, these are what to look for, monitor, and so forth. It's just-in-time learning, and we can no longer expect to push everything through our brain or one brain. It's just not possible. I'm sorry, yes, thank you.
I'm going to build on that and say, help me reconcile the gap between implementing the new technology that is going. People can now have wearables at home that in real time will give them their glucose level, their heart rate variability, it'll tell them how well they slept, but yet we're not even implementing this in our own hospitals, which hypothetically are monitoring you more closely, but not really anymore. So there is a gap in adoption of new technology and translating that. And by the time we adopt it, it's already going to be old technology, and there'll be newer technology. So help me reconcile that gap.
So the healthcare moves slowly. We are reluctant to bring in new technology unless there's a randomized controlled trial. We put security concerns around patient data that are real. We have HIPAA concerns around privacy. All of those are necessary barriers to doing what you're suggesting. However, they should all be overcome. It requires us to rethink it. Personally, what you were saying to me, all right, here's something controversial. I think every newborn in their umbilical stump should have a chip placed that will then enable us to track their health and physiologic signals for life. It's perhaps going too far, but that's the type of, we should be able to do that, in my mind, if we're really going to look at population health. However, the other aspect about that is accuracy and artifacts. So if you're going to be applying models to clinical decision making, and they are going to be believable, explainable, and actionable, the believability is really important. Now, we all know that there are a lot of artifacts in the ECG signal, blood pressure, arterial waveform. We all know that. They need to be accounted for in models. We cannot account for variability in time and in artifacts on the type of monitoring that you're referring to right now. And therefore, I would be really suspicious about them being plugged into a model upon which I'm going to be making a decision about that patient's health. Yes, and then Ken.
I greatly appreciated this talk,
Thank you.
particularly the part about compliance versus elastics. And I think one thing you brought up was that sometimes the system has to be able to respond to higher levels of illness, be able to expand, contract, that sort of concept. With the data that you've been collecting, I'm wondering if you might address one of the biggest problems we have in the ICU, which is just provider burnout. And we've had a tremendous amount of nurses go through ICUs in the last few years because of COVID. From the physician side, ICU medicine is one of the highest burnout rates in all of medicine. And surely one of the most important parts of all this is to have some sort of consistency in the workforce, to make sure that the workforce is always there to meet the needs of the patient. Just wondering what your insights are on that.
Boy, that's an important problem to solve, isn't it? So I have a couple of thoughts around it. First, it's real. And there are many variables affecting it, particularly the relentless work that occurs in the ICU and the pressures that are coming. My experience is that the people that I've had the great privilege to work with over many years always rise to the occasion. There's a need, people are going to do it. They're never going to abandon a patient or their colleagues. The second is that there are almost universally people that want to do things not only right, but in a way that's really effective and perhaps innovative and new. If we confine people to doing mundane tasks in our intensive care unit, like all of the notes and all of the authorizations, whatever it is, it's that mundane work that pulls you away from the care you want to provide to a patient or the way you want to think about it. We don't provide space for people to think. We've got to provide that and then to talk. I think AI will help us because it's going to enable us to aggregate a whole lot of information that you can use. It's not going to tell you what to do, but it's going to give you aggregated data instead of having to do that step by step. Ultimately, we will get to some decision support. Here's the other thing we need to do. These things, they need to be thrown away. Everything should be voice activated. Anyway, Ken.
I have friends outside of medicine who are really afraid that driverless cars are coming. And within medicine, every once in a while I hear people talk about the fact that AI will eventually make us obsolete. So I'm just curious about how we train people in coming up through their medical education to embrace technology and understand the benefit that it can really bring.
I don't think it's going to make us obsolete. I think it's going to make us so much better.
Yeah.
Because we're going to be aggregate. We will have machines that will aggregate the information that we can't put through our brain, and allows us space to be thinking about how to use that information, how to move things forward. I heard that a lot. The fear of automation, we're going to be out of business. I don't think that's the case at all. I don't think that's the case. I think it's going to change the way we work, but change it for the better.
But you didn't say anything about training. Where is that?
Oh, training starts in the medical schools. There's no point trying to train our residents and the fellows. Training has to start in the medical schools, and there are a number that are doing it. I know that Harvard Medical School has got set programs around the use of modeling, machine learning, and so forth. The education is not so much, there's core knowledge to be obtained, but the other important information is where to go to get the information you need. It's about information access.
I have a question just to make sure I understand your concept about those four categories, resiliency and variability, etc. Well, and I know we talked about that a lot with regards to our practice here in pediatric cardiology. I guess the way I used to conceptualize it, and maybe that's wrong, is that the consistency, a consistent type of approach provides you the base from which you can then expand on and be more in the resilient bucket, but it provides you that certainty to make sure nobody in the team gets left behind, and you have a certain task-oriented approach that excuse me, that has you cover the bases, but then you expand from that and become a more resilient team that allows you more to adapt to new circumstances. And the reason I ask that is because of something you said earlier in your talk, where you said a team is always heterogeneous. Not everybody's going to be able to move into that top right corner of your chart there. So is there a role for that consistent or more task?
There's always a role. There's always a role for that. I think when I look at the shift between those various categories, it's who's recognizing the shift is necessary, and the team may do that, but usually it's an individual or individuals that are recognizing it. So, and then you roll out a consistent way in which we're going to place a patient urgently on ECMO during cardiac arrest. You know, that's the consistency that develops. Well, I really appreciate you being here and for your questions. Thank you very much. It's been a great pleasure.